Welcome to the deep dive. Today, we're jumping into a really critical area, hypertension essentials. We're aiming to build, well, a really solid evidence-based foundation. This is specifically for you, the medical professional listening in. The goal is to make sure you walk away clear, not just on definitions, but the latest clinical thinking and the pathophysiology behind it all.
Okay, so let's unpack this. We've got source material that takes us right from the core definitions you absolutely need in practice, all the way through the global picture, the epidemiology, and then right into the, frankly, cutting-edge science. It shows why hypertension is, well, a lot more complex than just high numbers on a cuff.
Absolutely. And I think for anyone learning this, especially medicine, the key thing is integration. Diagnosis has to start with getting the measurement precise. That's non-negotiable. And then managing it effectively means really understanding the drivers underneath. And those drivers, well, they're evolving fast with the new research. So we're here to make sure that accuracy, both, at the bedside and in how you think about the disease, is absolutely solid. Okay, let's start right there. The non-negotiable diagnostic numbers. For a confirmed adult diagnosis in the clinic, what are those key thresholds?
Right, the clinical benchmark, it's still that confirmed office systolic BP of 140 mmHg or higher, or a diastolic BP of 90 mmHg or higher. That's the line. And important for pediatric colleagues, hypertension in kids isn't a fixed number. It's defined as a BP at or above the 95th percentile for their age, sex, and height.
That 140 over 90. It's the standard cutoff, yeah. But the sources, they really stress that the risk doesn't magically start right there. They talk about this continuous log linear relationship between BP and bad cardiovascular outcomes starting way lower. So why do we stick with 420/90 for the diagnosis?
That's a really important distinction. It's the definition driven by pragmatism and by the evidence base for treatment, the continuous risk curve. It tells us lower is generally better, sure. But 420/90 is where the studies definitively show that the benefits of starting medication usually outweigh the risks and the costs. It's essentially the trigger point for saying, okay, the evidence supports pharmacologic intervention here. It's not where the risk begins, it's where the benefit of treatment is clearly established.
Okay, that risk versus treatment benefit threshold distinction is vital. So to help guide treatment decisions, we use classification categories. Let's quickly run through those main ones.
Sure. So first you have non-elevated BP. That's less than 120 systolic and less than 70 diastolic, nice and low. Then there's this really important category. Elevated BP, systolic 120 to 139 or diastolic 70 to 89. This was brought in to flag people who need lifestyle changes, even if they don't meet the drug treatment threshold yet.
Right, a warning sign. And then you get into actual hypertension grades, grade 1, grade 2, all the way up to grade 3, which is severe readings like 180 over 110 or even higher. And we also need to mention isolated systolic hypertension, right? That's super common in older adults.
Yeah.
Systolic 140 or more, but the diastolic stays below 90.
Exactly. And that classification framework helps, but then we have these clinical phenotypes, different scenarios that can really complicate things in practice. We know most cases, maybe 90%, are primary or essential hypertension, meaning we can't pinpoint a single identifiable cause, but we always have to keep an eye out for secondary hypertension. That's the 5–10% where there is an underlying condition driving the pressure up, maybe kidney disease, an endocrine issue, something potentially fixable.
And then you get the measurement headaches. White coat hypertension, high in the office, maybe 420/90 or more, but totally normal when they measure it outside the clinic.
Yeah.
The flip side, masked hypertension. That often feels more dangerous, doesn't it? Normal in the office, say less than 440/90, but high when they're out and about. Usually that's an average home reading of 135/85 or more. Why is missing that one such a big deal?
It's insidious, exactly, because these patients often seem fine during a routine checkup. They might be younger, maybe high-stress individuals, their resting BP in the clinic is normal, but they could be having significant pressure surges during their day, or crucially, at night, they completely fly under the radar. But their total cumulative exposure to high pressure is huge, and it can lead to organ damage without anyone realizing it until it's quite advanced.
Yeah, that's a worry. And finally, the really tough one. Resistant hypertension. Can you define that failure point for us?
Sure. Resistant HTN is specifically defined as failing to get the BP below that 190 target despite being on maximally tolerated doses of 3 specific types of drugs: a diuretic, a RAS blocker, like an ACE inhibitor or AOB, and a calcium channel blocker. Plus, you have to be confident they're actually adhering to lifestyle advice. But critically, before you label someone with true resistant hypertension, you absolutely have to rule out pseudo-resistance.
Which, let's be honest, in the real world often boils down to adherence issues.
Yeah.
Or maybe measurement error.
Precisely. That's usually the first place to look. Are they actually taking all three medications as prescribed? Or is their white coat effect so strong that your office readings are just artificially high? That's pseudo-resistance. So the very first step in managing suspected resistant hypertension is always a deep dive into adherence and making absolutely sure your measurement technique is spot on. Now, stepping back a bit, we need to get a handle on the sheer scope of this. It's huge. Hypertension affects over 1.2 billion people worldwide. And what's really striking now is the shift in burden. It's increasingly falling on low and middle income countries.
That's interesting. Is that shift mainly because people are living longer in those regions, or is it more about, say, changes in diet, urbanization, maybe less access to diagnosis and treatment?
It's likely a mix of all those things. Age is definitely the strongest single predictor. Your lifetime risk of getting hypertension is over 90% if you're still normotensive at age 55 or 65. It catches up to most people. But the rising tide in developing nations strongly suggests factors like urbanization, the shift towards more processed diets, and probably gaps in healthcare systems for systematic screening and management. We see high prevalence pretty much everywhere, though. 65 to 75% of adults will develop it by the time they're 65 to 74. And some regions stand out. The Middle East and North Africa, for example, can see prevalence hitting 25 to 40% in adults. And we also see prevalence increase in women after menopause.
Okay, so let's quickly nail down the non-modifiable risks, the things that give us clues about lifetime risk but we can't change.
Right. Number one is advancing age, as we said. Then genetics family history roughly doubles your risk. And we do need to consider ethnicity. The evidence shows higher incidence and often more severe hypertension in populations of Black African or Afro-Caribbean descent. Important clinical consideration.
Okay, now for the actionable stuff, for the MD in the clinic trying to prevent or manage this. What are the modifiable risk factors where we can really make a difference?
Top of list, no question, is obesity and being overweight. It's considered the most significant and modifiable factor. And it's not just the extra weight itself. It drives hypertension through increased metabolic demands, volume issues, and crucially, sustained activation of the sympathetic nervous system.
What about other big ones like salt? How does high sodium intake play in beyond just, holding on to water?
High sodium intake is critical, yeah, especially if it's combined with low potassium intake. See, low potassium actually makes it harder for the kidneys to get rid of sodium effectively. So you get this double whammy leading to volume expansion and pressure increase. Then you add in a sedentary lifestyle, drinking too much alcohol, and chronic psychosocial stress, which we know just floods the system with adrenaline and other vasoconstrictors via that sympathetic nervous system activation, and you've got a perfect storm of drivers.
So tackling those lifestyle factors, it can often be more powerful than just tweaking a medication dose.
Often, yes, especially early on. Getting those under control can have a massive impact.
All right, now this is where I think it gets really fascinating for clinicians who might have learned the basics a while ago. For years, the focus in teaching hypertension was heavily on the kidneys and the renin-angiotensin-aldosterone system, the RAAS. But the latest evidence, the EBM, it really reframes hypertension. It sees it as a disease driven by much broader systemic processes, particularly involving inflammation in the immune system.
Exactly. This is a major shift in thinking. We're now looking at, well, maybe 4 key interconnected areas driving the pathophysiology. First, this concept of low-grade inflammation. There's solid evidence now that immune cells, specifically T cells, actually infiltrate key organs, the kidneys, the blood vessels themselves. And there, they release inflammatory signals, cytokines, that cause direct damage to the vessel walls and also mess up how the kidneys handle sodium.
Wow, okay, T cells causing high blood pressure, that sounds pretty revolutionary. But how does that translate to the clinic today? I mean, our tools are still cuffs and diuretics and ACE inhibitors, right? It's just theory for now?
Not entirely academic. It provides the why behind maybe why some patients don't respond well to traditional drugs. It explains the underlying pathology that those drugs might not fully address, and it absolutely points towards future therapies. Plus, this inflammatory environment connects directly to the second big area, the gut microbiome.
Ah, yes, the gut-brain axis, or in this case, the gut-DT axis. Tell us more.
So dysbiosis, basically an unhealthy balance of bacteria in your gut, leads to the gut lining becoming a bit leaky. This allows bacterial metabolites, byproducts, to get into the bloodstream. And these metabolites, they are often pro-inflammatory, they circulate systemically, and seem to directly ramp up sympathetic nervous system activity. So your gut health is literally sending signals that can raise your blood pressure.
Okay, so the immune system and the gut are kind of stirring up trouble systemically, which then feeds back into the more classic hormonal systems we already knew about.
Precisely. That brings us to the third area, the neurohormonal crosstalk. The interaction between the RAS and the sympathetic nervous system, SNS, isn't just additive, it's a vicious cycle. We now understand that angiotensin II doesn't just squeeze blood vessels, it also acts centrally in the brain to increase sympathetic outflow. That increased sympathetic activity then stimulates the kidneys to release even more renin, which makes more angiotensin II. You see the positive feedback loop, it becomes self-sustaining and drives the pressure ever higher.
A real vicious cycle. And the end result of all this inflammation, gut signaling, and hormonal overdrive is actual physical damage, right? Happening right in the tissues.
Yes, that's the fourth piece, local tissue damage. All this systemic activity, the RAAS activation, the inflammation, the oxidative stress, it causes direct harm within the walls of blood vessels and in target organs. It leads to inflammation locally, scarring or fibrosis, and eventually the arteries become stiff and less responsive. That's the structural damage that makes hypertension progressively harder to treat and leads to organ failure.
And that sustained damage, the structural and functional changes, that culminates in what we clinically call hypertension-mediated organ damage, or HMOD.
Exactly. HMOD is the clinical term for those measurable changes in the target organs. Heart, brain, kidneys, arteries that are a direct result of the prolonged high pressure.
What's the real clinical punch of finding HMOD early? Say you spot something like microalbuminuria or maybe some LVH on an ECG, even if the patient's office BP is only, say, grade 1 hypertension. How much does that change their outlook?
It changes it dramatically. Finding HMOD gives you incremental prognostic information. That's key. It means that across any BP category, the presence of HMOD significantly worsens the patient's cardiovascular risk profile. So that patient with grade 1 hypertension but with evidence of HMOD has a much higher chance of having a stroke or heart attack down the line than someone with the same BP numbers but no HMOD. It's a clear sign that silent damage is already happening and progressing. It tells you that you need to be more aggressive with your BP control to prevent overt clinical events.
And what are those main clinical events, the consequences of HMOD that we're ultimately trying to prevent?
Well, the big categories are cerebrovascular disease, that means stroke, but also cognitive decline and dementia. Kidney disease, both acute kidney injury and chronic kidney disease leading eventually to failure. And then significant heart disease that covers heart failure, both types, atrial fibrillation, ischemic heart disease like heart attacks, and even structural problems like valvular disease. We have to remember, hypertension is still the single most important modifiable risk factor for death from all causes, and particularly from cardiovascular causes globally.
Okay, powerful stuff. Let's pivot then to the absolute foundation of managing this, getting the measurement right in the first place. Precision is everything here. We need to go beyond just reciting the protocol and really talk about the common mistakes in the clinic that can completely throw off a reading and lead to misdiagnosis or mismanagement.
Absolutely critical. Accurate measurement starts before you even put the cuff on. Patient preparation is rigid for a reason. They must be seated comfortably, back supported, arms supported at heart level, legs uncrossed, and crucially, they need to have rested quietly for a full 5 minutes. No exceptions.
What actually happens physiologically when those simple rules get broken? Say the patient is chatting away while you take the reading, or they rushed in and haven't emptied their bladder.
These are the traps. If the patient is talking, that can easily bump their systolic pressure up by 10, even 20 mmHg, a full bladder. That can add another 10 to 15 mmHg through sympathetic stimulation. Arm not supported at heart level. You get errors from hydrostatic pressure, lower if the arm is too high, higher if it's dangling down. And definitely no exercise, smoking, or caffeine for at least 30 minutes beforehand. And that common mistake of rolling up a tight sleeve, that acts like a tourniquet, constricting the arm, and can easily add 10 mmHg or more to the reading.
Wow. So just fixing those basic procedural things, making sure they rest, arm is right, bladder empty, sleeve loose, could literally downgrade someone's diagnosis, maybe from grade 2, needing multiple drugs, to just elevated needing lifestyle focus.
Absolutely. The clinical impact of just getting the preparation right is enormous. Then comes the equipment itself. Use a validated, calibrated device. And cuff size is non-negotiable. The inflatable bladder inside the cuff needs to wrap around 75 to 100% of the patient's upper arm circumference. Too small a cuff. It overestimates the pressure, sometimes significantly. Too large is less common, but underestimates it. If you have a patient with significant obesity where you just can't get a proper upper arm cuff fit, only then should you consider the lower arm or wrist as a less ideal alternative, following specific protocols for that.
Okay, and a quick pearl for the actual measurement in the office. It's never just one reading, is it?
Never. Standard protocol is 3 measurements spaced 1 to 2 minutes apart. And here's the crucial bit. You discard the first reading. The BP you actually record and make decisions on should be the average of the last two readings. That first one is often artificially high due to the initial alerting response.
Got it. Average of the last two. And that very first visit, you need to check both arms, correct? Why is that initial comparison so important?
Yes, mandatory at the first visit. Measure BP in both arms. If there's a consistent difference in systolic pressure of 10 millimolar G or more between the arms, all future measurements should be done on the arm with the higher reading. A significant, persistent inter-arm difference isn't just a curiosity. It can be a red flag for underlying vascular disease like subclavian stenosis or even coarctation of the aorta. Needs follow-up.
Right. And we also need to think about orthostatic hypotension, especially in older patients or those on multiple meds, maybe feeling dizzy.
Definitely. Orthostatic hypotension, or OH, is that drop in BP upon standing, defined as a fall of 20 mmHg or more in systolic and/or 10 mmHg or more in diastolic, measured at 1 minute and/or 3 minutes after standing up from sitting. It's really common, can affect up to half of older adults, and is a major cause of falls. So, screening by checking standing BP is essential if they report any suggestive symptoms like dizziness or lightheadedness.
Okay, and finally, let's touch on getting readings outside the clinic. Out-of-office monitoring is vital for catching that white coat or masked hypertension we talked about.
Yes, two main ways. Home BP monitoring, or HBPM, is very practical. The patient uses their own validated monitor. Standard protocol is twice a day, morning and evening, ideally before meds and before breakfast, and then again in the evening. 2 readings each time, 1 minute apart. Do this for at least 3, preferably 7 days. You average those readings, discarding the first day usually, and the diagnostic threshold for hypertension based on HBPM is an average of 135-185 mmHg or higher.
And the other option, ambulatory BP monitoring, ABPM, gives that full 24-hour picture.
ABPM is really the gold standard for assessing the total BP load, looking for that normal overnight dip, or catching dangerous nighttime surges. It's a device worn for 24 hours that automatically takes readings, typically every 15-30 minutes during the day and 30-60 minutes at night. Key point. For the results to be considered reliable, you need at least 70% of the attempted readings to be successful. This is how you truly unmask hidden patterns that clinic or even home readings might miss. So if you bring all this together, really understanding these core definitions, the classifications, and especially mastering the accuracy of measurement, that whole piece, it lays the essential groundwork for everything else. You simply can't make good decisions about treatment, especially in complex situations like resistant hypertension, or even just getting an accurate reading in someone with atrial fibrillation where automated devices can struggle. You can't do any of that well without nailing these fundamentals.
Right. So we've covered the definitions, the numbers, the categories. We've dug into the why, the consequences like HMOD, and these newer drivers like inflammation in the microbiome.
Yeah.
And we focused on the practical how, getting that measurement right, avoiding the common pitfalls. Hopefully you, the listener, now have a really fortified, up-to-date foundation to approach your next patient presenting with blood pressure concerns.
And maybe this leaves us with a final thought, something for you to mull over. Given this emerging EBM that paints hypertension, at least in part, as a disease of low-grade inflammation, maybe linked to the gut microbiome, how might our current treatment approaches need to evolve? Right now, they mostly focus on fluid dynamics and vascular tone with diuretics, RAAce blockers, calcium channel blockers. Will we or should we start incorporating therapies that more directly target these inflammatory or microbial pathways in the future? That's something to really consider as we move forward in cardiovascular medicine.